There is an ongoing revolution in multiple myeloma, particularly in advanced relapses. Immunotherapy is now the backbone for patients fit and in some way that need the best effectiveness as possible according to an endpoint of an MRD negativity status, that is the ambitions that we have with the best patient in terms of performance status and in general with the young age in which we want maybe to correlate with the cure of our treatment. And in the same time, we are going also to revolution the management of every patient beyond immunotherapy. And in this patient, we have several options that have become available. One of them is Selinexor that we use in combination with the bortezomib dexamethasone according to Boston trial from second line of treatment. And we have seen excellent sub-analysis in patients that are proteasome inhibitor naive, and particularly when used in second line. In my idea and my clinical experience, the toxicity is not a problem if prophylaxis is adequate, if we in some way balance the need of our patient according to a very good compliance, to a tolerability that is also related to a drug that is orally available with bortezomib that is a subcutaneous drug. I think that Selinexor can be used in a wonderful way after daratumumab, lenalidomide, dexamethasone, and in general in LEN refractory patient. Let's not forget that we can use also Selinexor as single agent according to STORM trial in heavily pretreated population. I think that in this setting the idea of having the possibility of disease control with an oral drug is something that we really have to care about, particularly if we consider that this drug is really fast in its action and we can in some way control in a domestic setting in every pretreated is something that we really need. Another really important drug that has been available also in my country, in Italy, is Melflufen, melphalanflufenamide. This is a new concept of chemotherapy, the idea of having a chemotherapy without any great toxicity, really personalized, really focused on the myeloma plasma cells, and I think that is another wonderful idea for heavily pretreated, frail population, and also for the ones that have a not so excellent logistic, because this drug is possible to be 1 monthly administration every 28 days, fixed dose with a very good compliance due to absence of relevant adverse event. I think that for a disease control this can be considered, but I think that we are going to discover other use of the drug, and this can be also a wonderful bridge to new immunotherapies, and in general can be useful for patients that want a period of more relax, more comfort according to a very good schedule. So I think that Selinexor and Melflufen are for sure drugs that we are able to use, waiting for the positioning of other drugs and of other combination also based on these drugs. We know that there are ongoing trial EMN29 that is going to combine Selinexor with pomalidomide. This could be another ideal triplet that can be used also in a represented setting, and I'm curious to see also more data potentially also from real world where it could be possible of Melflufen in other combination. I know that there is not in this moment clinical development, but the idea of combining the Melflufen with the bortezomib, so a proteasome inhibitor, in the idea in general also with the combination with the daratumumab, the idea of potential rechallenge with this drug according to Anchor and Lighthouse clinical trials are something that we should explore more, waiting for the future. And I think that is really important to care also about the patient, because in this moment we need to understand which is the life after immunotherapy or without, in the one in which there are contraindications to use bispecific antibodies and CAR-Ts.